Welcome to Never the Same. Today, we're bringing back a conversation that's especially meaningful to me. One we recorded in partnership with Aetna CVS Health before starting the Never the Same podcast. The discussion features Dr. Melissa Dundas, a pediatrician and adolescent medicine specialist whose approach to youth mental health is both practical and deeply compassionate. You'll hear right away why I wish she could be everyone's doctor. She has this wonderful way of making people feel heard and understood that we all can learn from, whether we interact with young people at work or at home. Joining me for this interview is Kristina Zurich, then Mossgraber, SafeSide Prevention's lived experience lead. Though recorded earlier, the insights and strategies discussed here are as relevant as ever. Here's our conversation.
Well, thank you both, everyone, so much for having me here. It's been a really interesting journey, being able to become involved with suicide prevention. As a pediatrician and adolescent medicine specialist, part of our formal training doesn't encompass suicide prevention and really how to ask those questions, how to format visits, how to support patients and their caregivers. And so while I was a fellow at the University of Rochester, Tony had actually found me and we collaborated on a previous project, which actually gave me more education with regards to this area. I would say the number one thing is to actually really establish rapport with youth. It might be an area that they're not comfortable speaking about. They have been told not to talk about it. And when they come into our space, we really want to center them and let them know, like, this is your space, this is your journey, I'm here to listen. And then build that form of trust with them. And then it just gives them that opportunity to really be able to discuss what's going on.
Yeah. And I think that can be really hard, when you're asking these kinds of questions. I mean, Melissa, you ask all kinds of questions of youth that are uncomfortable, I'm sure, but they're all uncomfortable in a different way.
Yeah.
For this one, I mean, I can share some ideas, but I'm just wondering what your thoughts are about, like, how do you address this particular topic? Maybe how you would typically bring it up, and we can then chime in on our thoughts.
No, absolutely. So I tend to use what I call a graduation process. So I start off with saying, how are you today? How were you the last couple of days? How have you felt the last couple of weeks? And so it's not this right off the bat asking them, are you having thoughts about wanting to end your life? Are you having suicidal thoughts? Because with teens and youth, that might come off as too much to start off, and they may not feel like they can connect with you. So I like to start just very soft with them and then lead into that specific question.
That's really interesting. Yeah, I think that's true of adults too, actually.
Absolutely.
I think it depends upon our own comfort. Like some providers need more of a ramp in just to feel comfortable bringing it up. And then some patients need more of a ramp in. Mm-hmm. Even when somebody's coming already maybe expressing other kinds of distress or depression. Mm-hmm. One phrase I sometimes say, well, how bad has it gotten? Mm-hmm. And then maybe asking, has it ever gotten so bad that you've actually thought about ending your life? And moving it into that way, that it makes the question kind of a pain thermometer question. Mm-hmm. I'm expressing, by the way I'm asking it, I'm telling you, I understand that suicide is about things feeling really, really bad. Mm-hmm. This isn't just a question I'm asking for me. Mm-hmm. This is a question because I want to know your experience.
Yeah, I definitely. It's interesting because, from my perspective of both working with folks and, being a patient or a former patient, myself, I even think about with my primary care physician who got to know me really well, but even when I knew she had to ask about it, I would get anxious. I could feel myself,
really?
Even with the relationship we had, it's an uncomfortable topic. Even living in this space, it can be really tough,
What would make you feel nervous? Like it could get, I guess.
Yeah, it's interesting. It's just, I think And it's not that way anymore. It's dissipated, but I think especially when I was earlier in my recovery, or when I think I felt very vulnerable. And I think whenever we feel vulnerable, things can feel a little bit scary. And I think I just felt that feeling of like almost, oh gosh, what if I say the wrong thing when she asks?
Yeah.
And I think a lot of times, especially with our youth too, they're worried about,
Totally.
what if I say the wrong thing? What's going to happen?
Right. Who's going to know? Is this going to get out of my hands?
Yep, exactly.
Right. Because we have and we have a system where that's a legitimate concern, right? Sometimes with good and important reasons, we need to take steps that are, more kind of increasing the intensity. But other times, there's also times where maybe we didn't need to, but people do move to coercive kinds of things and getting emergency kinds of services involved when maybe that could have been handled another way if the person felt more skilled and confident in being able to understand and respond. Both parts of that.
And that's particularly important with youth as well, because some youth may not understand the true definition of suicide. And so some individuals, if they're having a really tough day, may make comments that allude to that, but that's not actually what they're thinking of doing. And so that's why, from my perspective, doing that gradual process gives the youth an opportunity to explain truly how they're feeling. So that, again, you don't get all of these emergency services involved right there and then that can spook the child. They lose trust in us, never talk to us ever again.
That's a really interesting part, especially with much younger kids. Right. So what we've been seeing over the past several years is, ages of kids that we previously would have said, well, suicide is almost never happens. We're starting to see, unfortunately, in the youngest cohort of kids, those rates going up. And actually have a colleague at the University of Rochester, Ariel Sheftal, who is specifically focusing on these younger, because we know very little about those youngest, those youngest really children, but younger than 12 years old even, who are really expressing these kinds of things. Yeah, and she's especially focused on Black children and youth, where the research is even less. So she's really focused on kind of a doubly important area. When it comes to the kind of asking those questions, we've made a lot of progress in our field in instituting standardized screening. And I think it's hard to talk about connection without talking about how does screening occur and how does it go wrong. Wonder what you all, what your kind of experiences are with that. Screening is, it's helpful. If we don't have as part of our routines asking these questions, we're all going to avoid them.
Sure.
But what are some of the things that we can think of to make sure that that's helpful and not harmful?
Right. I'll jump in, Melissa, if that's okay. And
absolutely, yeah.
So, as you're saying that, Tony, all I can think about is, having been in an office where someone is, clearly they're reading the questions off the screen or knows them by heart and is just sort of typing them in and there's no response. And like, well, I'm not sure why you're even asking, other than you have to, right? And when you feel like someone's just asking because they have to, you're less likely to be honest and forthcoming because you don't feel a connection and you don't feel that they're actually really listening. It's funny because I'm an adult clearly, but I also have a mischievous like teenage side still about me, of course.
No.
Yeah. Not me, never. And every once in a while when that used to happen, I would be tempted to give, kind of an off the wall answer just to see if they'd even look up. I know that's my mischievous, kiddo side still. But it's funny because for me, I was thinking like, I wonder what would happen if I said something silly, not something to scare them, not some, and I was always honest, but it's interesting that sometimes that's what our brain does is it's just, I think for me, it was also trying to protect myself. No,
it's hard because there are, especially in primary care, there are 1,000 times 1,000 requirements.
Sure.
Whenever we don't know where to put something in public health, the first place we look is in primary care because it's a place where we can access people. And so it's understandable that it goes there. But I think sometimes we have to sort of like say, okay, in this very long list of things that we have to go through in a flow chart of a medical record, what are the things that can go fast and what are the things that do need that few extra seconds or minutes to talk about? What do you think, Melissa?
Yeah, no, definitely. It is more common than I think we talk about, where youth in particular may feel this inclination to not be honest with the first person who asks the set of questions. And typically that ends up being on an individual who may not be the medical person in the clinic. And then they get into our exam room and then we ask those questions again. And so a lot of us outpatient and primary care are striving to educate everybody along that pathway so they learn how to ask those questions. Even like your tone of voice can make a huge difference too, right? And just your body language. Kristina, you had alluded to, like, if we're sitting there just typing and asking these really sensitive questions, if I was in that position, I probably wouldn't be inclined to answer them honestly too. So voice, intonation, intention, body language, all of that really plays into whether or not a child, a teen, a youth is going to feel really forthcoming in that measure. But we do see that though.
Yeah, I mean, one way, while keeping the pace that really needs to happen, one way to convey, let's say a nurse is rooming a patient within a healthcare setting. One way to do that is to maybe a short preface to the question, saying something like, our whole team cares about your whole health, and I want to ask you something because we really want to understand your experiences. So I'm going to ask you a couple of questions that may be sensitive, but we really want to know.
Yeah.
And then go into it. Now, I don't know. I didn't, kind of check the time on that. It's probably 10 or 15 extra seconds. And that's not nothing when you have a lot of things to cover. Right. But I think, I think as a healthcare, we have to decide, might that be worth those extra seconds to get, even if we only got 10% or 15% more openness, more people who weren't saying who do, I think the cost benefit of an extra sentence or two might pay off.
100%. I would even go as far as saying that it could be life-saving, right? Which is the goal of all of this.
Oh, absolutely. Yeah. It sounds a lot better just, to reflect on that. It sounds a lot better than I have to ask you these questions. Yeah. Just even, there was one more sentence you added and it just sounds so much more inviting and caring and, genuine.
Actually, Pedro, could you pull up the clip that we have of a nurse in a primary care setting, in a telehealth setting, asking this question and kind of bringing it up?
Kayla, a nurse in a primary care practice, is talking with Ms. Calderon, who scheduled a telehealth appointment as a follow-up from a previous visit. In this practice, all patients are screened for a variety of physical and mental health concerns, including for suicide risk. Kayla has already asked some of those questions and is getting ready to ask Ms. Calderon about suicide. Knowing that these are sensitive questions, Kayla has asked Ms. Calderon if she has privacy to answer those questions and to let her know if that changes. Watch for how Kayla asks with the goal of connecting and better understanding Ms. Calderon's experiences.
I'm glad your sinuses are better, but I'm sorry you haven't been able to sleep well. I'll make a note to the doctor. So as you know, we care about every aspect of your health, including your emotional health. Are you okay if I ask you some questions?
Okay.
So the first question is, in the past few weeks, have you wished you were dead?
Yeah. So a couple things there, right? So one thing we didn't talk about before was asking if the person's in a private place. I think, in a telehealth setting, that's really, really key. And then also asking permission.
Right. The invitation.
That's exactly what I noticed too.
Yeah. Now, of course, the first objection, like you're going to hear, is like, "Well, what if she says no?" And, I think that it's like, but we have to ask, so what if she says no, right? But that objection comes from kind of a funny place. And I think it's sometimes we've been so trained to think a certain way about information that we forget that the validity of the information actually matters, not just the getting it. Because if she says no, first of all, that's important information, and that can be followed up on by itself, right? She was not willing to answer these questions about suicide. Okay. That tells us something, and we already know more than we would have if we just asked questions and then she didn't feel like.
Yeah.
Good point. But also, if somebody is telling you no, then if you had asked them, they probably weren't going to tell you the truth. Yeah, that's right. And so what's the point of having, we have to remember that the point of asking is to get data, and it's only good to get data if it's good data.
That's right.
And so that's I think pretty key in keeping that that the connection is important for connection itself, but also kind of like you said before, Melissa, it's also important for getting kind of valid and reliable information.
For sure.
And I love that ask for an invitation into that patient's space, right? So it goes along with asking permission. Can I ask these questions? Youth are very susceptible to that too. Like they have their own confines. They have that own space that they protect too. And so extending that or asking them for that invitation is just as important in pediatric care as it is in adult care, that as we saw in that video.
For sure.
Yeah. I think the one more thing that we can say about this kind of connection thing that we've been kind of talking about is if we remember that when we use the word assessment a lot, and in I think in the context of suicide, assessment really, you could almost find and replace that word with the word understanding. So if I say I want to assess, I want to understand a person's experience, not assess for a set of thoughts. Right. And if we change it like that and we talk like that, and even so, there's a set of questions I'd like to ask you to help me understand. People want to be understood. Not everybody wants to be assessed.
That's right. Yeah, that's
100%.
And they probably really don't want to be risk assessed, right?
Yeah.
I'd like to assess your risk now. It's kind of like, oh, is this going to hurt? But it is but most people do. If you say you want to understand them, okay, I'm up for that.
For sure. Yeah. I mean, that's something. I use the phrase "help me understand." I can't tell you how many times a day in so many ways, because if you just think about it,
like in
just
professional
in
personal
space, and
life.
You think about it, to your point of people want to be understood, and it's amazing how much more genuine, accurate information you can get when instead of perhaps going into a space of judgment or into a space of reactivity, maybe you just lead with, help me understand. Tell me more about that, right?
Yeah. And no, it's really good. So it's something that's probably a generally good skill, and then it's like critical when it comes to something that people really don't want to say.
For sure.
Right. And this can be one of those. Yeah. Well, I think we want to talk about in what setting will make a difference, and I think here our context, talking with you here, Melissa, is in primary care or at least healthcare. In your case, you work mostly in adolescent medicine, but I know you've done a lot of work in primary pediatrics as well. I think the first thing to say about what to do is to remember that the set of options are more than a mental health referral. A lot of times primary care professionals have been referred to as gatekeepers, right? Really don't like that. I mean, it's fine. It's not like the word police. It's not so much the word, but I think the idea is like they're a gatekeeper to a mental health referral. Now, first of all, you don't want to be a gatekeeper. You want to be a gate opener or whatever. Right, exactly. But even that, it makes it seem like your whole role is to identify and refer. Now, a referral is important, but it's not the only thing the only helpful and potentially life-affirming thing that a primary care professional can do.
Yeah.
No, absolutely. And we have to remember too that like not all areas have access to mental health providers, referral resources. And so in primary care, oftentimes we are the first stop for somebody. And so when we think about what those next stops are when an individual does endorse suicidal thoughts, wanting to harm themselves, the first question we ask is, well, how do you feel right now? Do you feel safe in this moment? Second thing we try to do in pediatrics is, who do you feel safe talking to? So thank you for like involving me, but whoever you live with, is there somebody at home that you feel comfortable talking to them about? And then the next piece is, well, because you are a minor, I do have to share this information with the person that loves you so much at home. How do you want to do this? How do you want us to share that information? And I use the term us so that kids don't feel alone in that process. And then once we invite whoever that loving human being is at their home, is talk about, can you keep them safe at home right now? What supports do you feel like you need? And then I will help connect you to those resources. And so it's not just a matter of us as the provider saying, okay, you've told me this. Now I'm going to open the gate and tell you where to go. Let me understand you, not just as the individual human you are, but as the context and the group and the home that you reside within. And what does the whole context of that living situation need, and figuring out what to do next.
Yeah. And for some people where the home is not as safe a place, there's other people in the community, schools, teachers, and we can expand what we, kind of what we mean by supports. So even, so you mentioned not everywhere has like access and availability to mental health. That's true. But even where there is access and availability,
It's really hard.
yeah,
It's really
there's
hard.
not people right. Well, many people don't want to go.
Yeah.
And if they do, it's often for a short time. And so it is, we can't have our entire strategy for suicide prevention when somebody presents in primary care rely on that. Because no matter how, first of all, there's probably never going to be enough behavioral health professionals to serve every single community. But even if there was, people are usually in care for a pretty short time. But they remain in primary care. So maybe they've gone and hopefully if us as behavioral health providers have done our job right, we've communicated back and we're working in close collaborations in some cases, and more, there's actual co-location and integration, especially in more urban or metropolitan areas. That's great. But usually that will be for a short time. So what can you do? So I think referring and also knowing where to refer in some, where it's available. There are more evidence-based suicide-specific treatments than we've ever had before. There's more research about that, and maybe in a different conversation we can go into more depth about those. But second, there are things that you can say and do that provide that support. And I think some of the things that you just shared were like you were speaking in a very collaborative way. And I think another one can be to help the young person make sense of suicidal thoughts. Because not everybody knows that, it's not that uncommon to have those thoughts, and it doesn't mean you have to act on them. Right? So it's not uncommon when you're going through those kinds of things that you might have thoughts like that. And, that's, I can hear that. And it's an important signal for us to listen to, because it means things are really bad. Things are really hurting. But it doesn't mean that you have to do that or that you will do that. And we're going to do whatever we can as a team to help you, not just not kill yourself, but we're going to do everything we can as a team so that you don't feel like you want to do that. And another thing, so that's one, is to help them make sense of that, understand that it's normal. But I think another is to offers a possibility that it actually can get better. We do know, we have quite a bit of research to say that if people engage, if especially young people engage with our teams and the kind of supports that we have and give it time, which can include a whole panoply of different kinds of treatments and interventions, engage with it with adults that they know, they can feel better. I mean, I can tell you, many examples of that from my own life and practice, and I can also show you a lot of research that shows people do get better. So, but we don't always let kids know that. Now you got to be careful because you don't want to say something that just feels like totally impossible to somebody sometimes. But I think sometimes we're so concerned about over-promising that we don't show any hope.
That's interesting. I think, it's interesting to hear you to say, and every time I hear you say it, and every time I hear, people say it, that, I know that it's not uncommon for people to have thoughts of suicide, especially when they're struggling, their brain is in so much pain. And when I share that with people, the people like, wait, what? That's, it's often surprising for people. And it helps kind of normalize the conversation when I'm having it with someone.
Because they've been kind of alone in it and just thinking it's just me.
Exactly. They've been alone in it, thinking it's just them, and then thinking if they talked about it, immediately there would be a transport, there'd be intervention, there'd be EMS involved, and it would escalate to a pretty traumatic situation. But just to hear like, wow, again, with everything going on in your life, it's not uncommon to have those thoughts, but it's an indicator to us that it's time to dig a little deeper and understand what might be going on. So start feeling better.
Yeah.
Yeah.
And then I think we can, in addition to saying those helpful things, normalizing, helping people put it into context, offering some hope, those kinds of things. Then there's also plans that we can make, and that don't take a behavioral health specialist to do. But so making plans for a person's safety. Now, there are different levels of doing that, right? There is an evidence-based intervention called the safety planning intervention that has several steps to it, includes kind of following up on those, on these plans, helping a person identify their warning signs, things they can do to distract themselves, people they can go to. And sometimes in a primary care setting that, or certainly an emergency department setting, it can be challenging to with time to do all of those steps. We want to aim toward that, and it might be that you have to sort of say, hey, we can just get started on this today, but I'd like you to come back on Tuesday and keep going with this. But I guess there's a couple things, though, that I would say, and I wonder what kind of what your common practice is with this, Melissa. There's a couple of things that I would say would be kind of first on the list to do, even if you can't, kind of go through an entire safety planning process, or maybe you don't yet have all the training and skills or personnel to do that. I don't know what maybe I could just ask you kind of what's your practice in your setting, and then I can share what suggestions they have for like, okay, if you could just do two things, what they would be.
Absolutely. So I can approach this from two very different points of view. Like one, having, at one point in my life worked in a community hospital where, we would schedule more close follow-up and do like some of those smaller portions to keep somebody safe, versus being at an academic center where I do have access to social work in my clinic. I do have access to a psychologist who can be readily available once that assessment, that humanism, that rapport has been built, to help coordinate what those next steps could be. But initially, what I would do with, if I had a youth or a teenager in front of me, is that I would again, just understand the degree of safety concerns in that moment. Do they have access to our clinic numbers so they can call us even after hours if they're going through a period of distress? Do they have access to other national phone lines? And do they have the ability to come back in a couple of days for a quick check-in? So I think those two things are like the simplest things that we can do that are actually really life-saving in that moment if we don't have extra things that we can provide them with.
Yeah, I love that. I guess what I might add to that is addressing means safety and trying to find out what are one or two things that could happen in the person's life that could really send them for a loop. So in our framework, we call those foreseeable changes. And in the notes to this episode, we can provide some additional links about this. And in fact, we can include a brief kind of 4-minute training in how to identify these and use them. We can include a link there. But the idea behind foreseeable changes is that before the person leaves, I really would like to know, maybe from the young person, from a family member, what would you say? What are like a couple of things that if that happened, you would think, oh no, I'm really worried about my daughter, or like, oh no, and finding out what those couple of oh no things, and then that can let you take the conversation to the next level. How likely are those to happen between now and Tuesday, when you're going to be coming back? And is this something that's likely or not, or unlikely? Would we know if it happened or would we not? Those are the kinds of things that can now get us into very concrete. So it's not sort of just, okay, what's a sign that you would know you were feeling bad? Well, those are good to do, but they're kind of more general. This is like really nitty gritty. What could happen that could really throw you off? And once you know that about a person, you can then begin to inquire about how predictable, how much visibility, how likely, and how soon is it to happen. And then I think the other, in addition to identifying those foreseeable changes, as we call them, is addressing means safety. And what that refers to is, to the extent that we can, trying to put distance between the person and the means that they might use to kill themselves. Yeah, and the way I think about that is I'm looking in two places. One, any means that this person has specifically mentioned before, and then two, any that are more common for that particular age group or culture. And so I might kind of think about those two things in terms of addressing those, because I would say of all the different public health interventions that we've had in suicide prevention, reducing access to the means when somebody is in the heat of that kind of suicidal crisis, putting some distance between them and those means is probably the most effective one. And we can't talk about that without talking about firearm safety, which pediatricians have really led the way in, which really means that really figuring out how can we keep firearms in a safe location if you have them in your home, and assume that the first two ways you would think of, the young person has already figured out. For sure. And then kind of go from there. And it's, this is not to say anything about, firearms in the home or any of that, but it's just that we know statistically that can make a suicide more likely. So if you have a young person at risk, that's a really dangerous combination. So you just want to think it through, and then kind of a couple levels down. I was just mentioning about different age groups and cultures, and that might be maybe a final really important topic. I know we only have a bit more time together today, Melissa and Kristina. So I wonder if we should talk a little bit about that. It's incredibly important about how do we address these concerns in a variety of different, we of course can't cover every possible cultural group, but maybe just some that we work with. What are the things that sometimes need to be adjusted, and how do we work with family members from different cultures? And Melissa, I know that you're there in New York City, and here in Rochester, we've got plenty of diversity as well. But I mean, you're really in the heart of migration, immigration, and all kinds of different meldings of culture. So I wonder what your experiences are in that regard.
No, definitely. I do want to say that it is actually such a privilege to be amongst so many different cultures, because that helps really educate clinicians in terms of how to just be even more generalizable and be able to connect with a multitude of different individuals from different backgrounds. But I would say from experience, the most important part is to understand what is somebody else's understanding of suicide and mental health. Right? I never want to assume that somebody who has recently immigrated here for whatever reason, that we share the same understanding or the same context of what that means. And so again, that's another invitation to say, hey, can we talk about this? The next part that we really try to do is to destigmatize it and say that, we don't really talk about it. I can say in my Caribbean culture, it's still very taboo to talk about suicide and mental health, but really saying that it's something that everybody from all shapes, sizes, genders, sexualities, races experience. So how can I help you feel comfortable in this space so that we can talk about it together? And there's no judgment here. But you have to approach it with a sense of you can't paint everybody with the same brush. And once you can actually put yourself into that position, then it's actually quite, I wouldn't say easy, but it opens up that conversation to speak with individuals cross-culturally and be able to treat everybody with the standard of care.
You mentioned that that not to assume that you have the same understanding. Probably true even within the same culture, but it's especially true across cultures. I was wondering, in your experience, what are a couple of areas where you've noticed there is that difference or disconnect?
Absolutely. So individuals' perceptions of struggle. So I've often encountered differences where, let's say, I'm working with a family that may have been born and raised in the United States. They're from an affluent community. The child has everything they could possibly want. And the parents are thinking, well, my child can't possibly be having these thoughts or can't possibly be suicidal because they have everything under the sun. And it's navigating that discourse and saying, well, sure, everybody can have all of these superficial things, but there's a disconnect somewhere for your child where they are suffering, and it's okay to acknowledge that. And then there's other situations where, with some of our migrant families who have really seen a lot more than any of us may see in our lifetime, may see that as the ultimate struggle and not necessarily the mental health component that either was there before, during that, or has resulted because of that, what they've gone through. And so it's really showing that irrespective of what your background is, this perception of, oh, this is a great struggle or there's no struggle, folks can still be struggling with suicidal thoughts irrespective of those differences. And it's how do we bridge that to say those things actually at the end of the day don't matter. It's the individual person and their own internal struggle that we have to center in those conversations.
Mm-hmm. Yeah. Yeah, that actually makes me think of another, kind of reaction that people sometimes have, especially in very close-knit families where the or cultures where the ties and kind of reciprocal ties and bonds are very important. I would actually even say that's in my own kind of Italian American family. That's true, and it's probably true in others as well. But I find myself sometimes having that same reaction. Like when like if somebody in my extended family is struggling, my first thought is well, how could they do that to parents, or how could they do that to their sisters? You know, like, and here I am, like, you know, I'm supposed to be the, you know, psychologist. I'm so open. Oh yeah, great. You know, this sister, you know, he's gonna be there for people, but within the context of my own family, I sometimes have that kind of thing, like, how could you, or you know, how could you say that? You know, I mean, so I have a lot of sympathy when, I guess, or empathy and identity or resonance with when a parent's first reaction is, how could you think that?
Sure.
You know, you know, I get that. You know, and we have to work with it to not, like, even though I also, another part of me cringes because it's like, that's going to totally shut the young person down. But I also really understand it. And I think it is a key to working with parents and families. Because I think sometimes those of us who work with children and youth, we do that because we really like them, you know? And sometimes I have seen in some settings where you can get to this place where, like, the kid's the hero and the family's the villain. And, you know, I think it's really important to avoid that. And I mean, the way you spoke before really avoids that. And I think that can be really key to just realize, like, you know, it's not that easy. It's pretty hard to be a parent. It's pretty hard to support people who are struggling. We have a member of our team who is a family carer. She cared for her brother for a couple of decades with with suicide, mental health, substance use concerns, and it's really hard. And I think if we go into those interactions sort of remembering that, and then even though we probably in pediatrics or child psychology, we tend to, like, you know, we're on the side of the kid. That's why we love this. Right. Just making really sure that we don't, even in our minds, kind of pit one against the other, and realize that adults, at least in general, are more likely to be supports, even if they're not perfect, even if they say things like I do, can still be a valuable resource.
No, definitely. And I think, to your point there, Tony, we're all human at the end of the day, right? And that's why we're lifelong learners, right? And as long as we recognize that, you know, we can have tendencies like that, we can act on them, right? One thing I have particularly found helpful with parents too, kind of in that situation where some parents will be like, well, why is my child doing this to me? It's gently reminding folks that the child isn't choosing this and isn't choosing to feel this way. This isn't a choice, right? And at the end of the day, no toddlers can be savage at times, but no toddler, child, adolescent, youth, young adult wants to upset their parents. No child wants to deliberately disappoint their parents. And I think when parents hear that, they really understand, like, okay, my child is suffering. This has nothing to do with me. Let me recenter this on my kid and get them the help that they need. And I think just, like, kind of helping reframe that helps the parent understand that, like, this isn't a choice. This is no different than diabetes or cancer or any other really terrible medical condition. We have to treat this the same way.
Well, that seems like a good, I don't know if you had more to say.
No, I just wanted to, I was just going to kind of reflect on what you just said, Melissa, and what, you've been saying, Tony. And, I've spent a lot of time working with kids in the schools, and we would go, through the warning signs, what to do. And definitely there'd be a young person who would say, okay, I heard what you said. I tried talking to my parent or my guardian, and they said, it's just teenage stuff. You're just making it up. You're manipulative. Cry for people ask me all the time, do people talk about suicide as a cry for attention or a cry for help? And I said, yes, because they need help, right? Because they're hurting. And so I just really appreciate what both of you are saying, but just kind of looking at it through the lens of, especially our young people, they don't always have the language and the tools and the understanding to verbalize what it is they need when they're struggling. So sometimes these actions or behaviors that can be sometimes dismissed and misconstrued as, behavioral or as being manipulative or this and that, are just like we're humans and, trying to need some of it. So,
yeah. And I think that brings us full circle to why, a primary care professional is not just a gatekeeper.
That's right.
Because it doesn't take a mental health professional to listen, understand, and be a different than maybe even sometimes a parent can be. And you can provide people with a different experience, and that's not nothing.
Yeah.
Might feel like something like, what can I offer? I'm not trained in this. What can I offer?
You have a lot to offer,
But
Tony. We all have a lot to offer.
A lot to offer, right? Very true. And I think that's a maybe an important note to end on, that people across the healthcare spectrum have a lot to offer, more than just identifying and referring. There are things that we can do and say and ways to listen that can really make a difference. So. Melissa, thank you for having this conversation.
Yeah,
Kristina,
it was so
this
great.
really
It's so
good to
fun.
talk this.
This is great.
I've learned a lot from
Me too.
this.
Thank you.